Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
We're going to move on to our next speaker all the way from Minnesota. Dr. Arpit, are you there?
Yes. Good morning. How are you doing?
I'm good. Good to see you. Good to see you.
You too.
From the Twin Cities.
Yes, sir. That's right.
All right. It's a great privilege having you here today. Just gonna go straight, and if you need to add anything about your background, please go ahead and do so. Dr. Arpit is a clinical assistant professor at the Faculty of Dental at the Division of Prosthodontics in the University of Minnesota. He completed his prosthodontics residency at the University of Florida College of Dentistry in Gainesville, Florida. He also had his advanced training in 1-year internship at the Department of Graduate Prosthodontics at the University of Florida Advanced School of Dental Sciences. He was also awarded a fellowship of the International Congress of Oral Implantologists. Dr. Arpit maintains a patient-centered, multidisciplinary team and evidence-based approach to patient care. He has been teaching for the past implant prosthodontics courses and digital dentistry for the past couple of years. He's a speaker. He's also a speaker for the Dentsply Sirona and the international team for implantology, ITI. Dr. Arpit, it is a pleasure to have you on Dental Webinar Series today.
There. How's that?
Yes.
Yeah.
Powerful. Thank you.
Sweet. All right. Good morning and welcome everybody after a beautiful lecture by Dr. Shovik. This is just the next one after that. He covered a lot of areas about hybrids and full arch restorations. My talk today will be mostly about single crowns or bridges, or even if you're doing multiple single crowns. Once you've placed the implant, right, you're planning for the prosthesis. How do you develop good aesthetics? And basically, how do you transfer that to the lab so that you can go ahead and make a final prosthesis that looks as natural as possible and the patient is as happy as possible, right? All right, so getting started, when we talk about aesthetics, right? So generally, if you look up the dictionary, right, the term aesthetics is, has one definition, right? And you can see that on the screen. However, right, if you talk to patients, different patients have different definitions for aesthetics. They have different expectations for aesthetics as well. Some of them want really white teeth. Some of them are okay with more natural looking teeth. And so it's just a very wide spectrum of, aesthetic expectations between patients. And so as dentists who cater to such a wide variety of patients, we need to be prepared, not just mentally, but also also with the skills that's needed to provide every patient with the kind of aesthetic that they are expecting out of the treatment. Okay, so going ahead, right? When you talk about implant aesthetics in particular, some patients, will be very happy with the implant on the left, right? Because they don't really care about the soft tissue fill or how it's looking. As long as the color matches, as long as the space is filled, they're perfectly happy. On the other end of the spectrum, you have patients who are expecting something that is on the right side of the screen, okay? So they are expecting it to look natural. They're expecting it to feel natural. They wanted to match the contralateral tooth. They wanted to match the adjacent teeth. And so the level of expectations is very different, is like right across the whole spectrum, right? And and both of them are okay. None of them is good, none of them is bad. Both of them are what they are. So going ahead, the most important thing that I found out, at least in my practice, right, is for me what works, as long as the implant is placed in the right position, right? Just as Dr. Shovik said, once the implant is planned ground down, once you decide where the tooth needs to be, the implant is placed, and once healing is done, how do you convert that to the final aesthetics? Okay, for me, it's the provisional phase, everything after the placement of the implant to the placement of the final prosthesis or the crown or the bridge. That's the time, that's the opportunity you have to go ahead and develop that aesthetic profile for that patient and for that case, right? So for me, this time period is where I use my provisionals. And interestingly, not a lot of general dentists or even specialists for that matter on the outside, they don't really provisionalize their implants a lot, because a lot of times people don't see the importance or this thing in provisionalization. They don't see why it is so important. Actually, the thing is that provisionals for me is one of the most important thing in the whole implant therapy, right? Why? That is because firstly, prevents the drifting of adjacent teeth, prevents drifting of the opposing teeth. Secondly, it's really convenient for the patient to not have to wait until after the implant is placed and the final prosthesis goes in, for them to fill that space up. Because a lot of times, if the patient is missing a tooth, one of the biggest concern is that little black hole, right? That is an aesthetic problem, right? Even if it's in the posterior, there's a tongue going there, there's the food, there's a lot of insult to that tissue that tissue is not really designed to endure, right? And so giving a provisional makes it a lot more convenient for the patient as well. On top of that, once the provisional is in there and the patient is biting on that, there's occlusion, there's all of those functions on there, it gives the patient an opportunity to basically go ahead and experience the implant, right? Experience the crown in there. If there's anything that needs to be changed, this is when the patient can tell you, hey, I like this, I like that. First, I thought this is good. Now I think we should go this way or that way. That basically gives the patient an opportunity to try the prosthesis before it is even finally made, right? Moreover, once that's done, the tissue is kind of healed around the provisional. So basically, it also facilitates the delivery of your final prosthesis. A lot of times when you're doing like a full arch of implants, single crowns or bridges, you want to keep the occlusion really stable on the other side when you deliver the prosthesis on one side, right? So that is where the provisionals help you as well. Going ahead, since the provisional is there after the implant is placed and before the final prosthesis is delivered, what is happening at that time? If you think about it, that is when the tissues are actually healing around the implant, right? This is where the tissues are developing around the implant. And when you have control over this phase of the implant treatment, you can modify it. And so you can basically facilitate the proper maturing of the healing tissues, right? And most importantly, once you have that under your control, that is when you can shape the emergence profile, right? So talking about the emergence profile, this word is thrown around a lot, right? Oh, emergence profile, implants, emergence profiles, and implant. The thing is, emergence profile is in everything. It's not just implants. It's in crowns, it's in bridges, it's in, hell, for that matter, even complete dentures, right? For my students, a lot of times when I have to explain to them what emergence profile means, they have never done implants. They've never restored implants, right? But what they've still done is complete dentures, right? So I use that to explain what emergence profile really means. So basically, if you compare these two dentures, right? Let's just consider these two dentures in front of you, right? The one on the left and there's the one on the right. Which of these would you feel is more aesthetic, right? Technically, if you see, both of them have the same teeth. It's the same teeth mold that is used for both of them, the exact same tooth mold. So what basically makes the difference, right? It is the pink portion. It is the gingival portion that makes the biggest difference between deciding whether the tooth actually looks natural or it looks fake, right? So if you can make it look as if the tooth is actually erupting out of the alveolus, just like a natural tooth does, right? If you can make the pink aesthetic look like the pink tissues look like they are supporting the tooth, just like the pink gingiva would with a natural teeth that would have kind of erupted naturally from the alveolus. That is what I call emergence profile. It is that specific shape at the neck of the tissue that is supported by the gums that gives it that look, right? So again, same thing as in a denture. Once you have that on your denture, right? The teeth is a teeth, right? It comes from the company, from wherever you can make it. There are certain things that you can control with the tooth, yes. But the second part of that aesthetic equation is the gingiva or the pink portion of your prosthesis. Okay. Once you have that right, it will automatically start looking more aesthetic, right? And if it looks as if it has erupted from inside of the alveolus, that is what I would call an emergence profile. Okay. So that brings us to the difference between a tooth and a dental implant. And I know this topic has been covered a lot, so I'm not going to go too much into the detailed nitty gritty of it. But basically, if you look at a natural tooth versus a dental implant, right? Restoring both of them, there are different things that you have to keep in mind. For example, when you retract gingiva around a, a normal tooth prep, right? Um, you have about 10 to 15 minutes after you take out your final cord, right, to make the impression. Why is that? That is because the tissue kind of falls in, right, and your margins are not clear. The same thing happens with the implants. However, the reason is kind of different. Why? Because both of them have different fibers in that specific portion of the gingiva, right? In case of an implant, it's missing the transverse fibers, right? And all it has is the circumferential fibers. And so because of that, the dynamic of that tissue is a little different. So that is one consideration. The second thing is that a natural tooth has periodontal ligament, while the dental implant is basically ankylosed in the bone, right? That brings us to the biology, which is different for both of them, and the bone healing versus the periodontal ligament applying forces on the bone to make it grow in a certain pattern, just like Dr. Shovik just talked about the Wolff's law, right? A lot of things in that way either. So going ahead, the implant, on the other hand, we are talking about mechanics. We're talking about force transfer, threads, what kind of connection, what kind of platform are we talking about? There are different materials. Different materials interact differently with bone, different kinds of bone graft, a lot of things that we're talking about, right? And at the end, the final thing that makes that tissue around the neck of the implant really stable is the position of the microgap, right? For example, if you compare like two implant systems, one system that has a platform shift, whereas the other system that does not, the only difference is the position of the microgap. Both of them have a microgap, right? Even with the, say for example, Astra or Strom, they have a platform shift, right? Um, However, in this case, what happens is the microgap is positioned horizontally on the inside as compared to on the external surface of that whole implant abutment complex. So that basically moves all the, bacteria or the healing a little bit more horizontally on the inside, and that basically creates a more stable tissue, not just bone, but also gingiva around that area has a lot more stability. Okay, so again, these are just some of the factors to consider when you're restoring a tooth versus restoring a dental implant. And so the emergence profile, right, is one of the most key factors that we're talking about while restoring implants. Okay, so where does this whole thing come in? The thing is, say for example, you're doing an anterior crown or an anterior implant, right? If you look at an actual tooth and section it at three different places, you'll see that starting at the apex, the cross section is pretty round. In the middle, it gets more towards the oval, right? However, at the level of the cervical region, okay, it gets a little bit more rounded, triangular in shape. Now, keep in mind, this is the exact level where you will be restoring your final crown to, if you're restoring an implant, right? And so, um, to change that shape between, the shape of the implant to the shape of the natural tooth, um, that is where all the fun is. Okay, same thing with a posterior tooth, right? You put an implant in a molar side, and you wait for it to heal. You take the healing abutment off, and you realize that, hey, yes, I have good space, the implant is placed well, but now thinking about it crown down, um, I need to restore a molar. There needs to be a molar there. And so you realize that the shape of the molar at the cervical level is very different from the shape that the implant is, right? Why? Because the implant, any implant system, would essentially be circular in shape. And so to transition that shape from a circular to that specific shape for the tooth, right? That is what I call developing the right emergence profile. And how do you do that? You do that by uh, customizing or tailoring your provisional to that specific site. So one thing that matters in this case is what kind of implant you're using and whether it's placed right or not, right? Why crown down approach really matters is because of this. Say for example, you're placing an Astra, right? An Astra EV that does not have a collar, polished metal collar. So you go ahead and place it. Ideally, you want the platform, the restorative platform of the implant to be about 3 millimeters below the planned mucosal margin. Okay, I'm going to repeat that again. Ideally, you want the platform of the implant to be about 3 millimeters below the planned mucosal margin of, right, of the tooth, basically. That being said, when you place it in the right position, you have enough room to develop the tissues in that area for it to look like it is naturally erupting from the bone. If you place that implant too coronally or too shallow, what you have is the occlusion is right where it is, right? And now, so because you have limited space, you need to fit that tooth in there. And so basically you end up with a shelf. Now this shelf is not going to be really conducive to a long-term health of the tissue or the implant, right? Um, the tissue is not going to develop really well there either. So that is one problem that you might run into. The other problem is implants that are not, placed with the crown down approach. So when we talk about, say, the Strawman implant, right, with the polished metal collar, that is supposed to be placed where the junction between the polished and the titanium is at the level of the bone, right? The connection is 3 millimeters below the planned mucosal margin. Uh, Sometimes you have too much room, and so what ends up happening is you have the crown that is too tall on the implant. So in case if there is a minor angulation issue, now you're just putting too much force on that implant, okay? And so at the end, you just end up complicating things even more. So as I said, right, provisionalization is the key to a good aesthetic outcome. Now there are multiple ways of how you can provisionalize, right? You can have one case where it's just a single tooth or a bridge, or just one section of the arch. On the other hand, you have cases where it's a more of a full arch case, right? Just like Dr. Show talked about a hybrid case, right? And each kind of case, you can do it two ways. You can do it either directly in the mouth, or you can do it indirectly in the lab. And the process is really simple. So the abutment that you use for this is called a provisional abutment. And again, it can come in a variety of materials, a variety of sizes as well, that is specifically tailored to that specific site and that specific implant size. Talking about materials, it can either be made out of titanium or it can be made out of PEEK, whichever you prefer. Okay, so talking about the main technique of how I make my provisionals, or how I teach my students to make the provisionals, is, say, for example, this case, right? This implant was placed, as you can see, there's an occlusal view. You see the position was really good. Coming out from the occlusal, we have good tissues on the lingual, good tissues on the buccal as well. And what I do is, generally, before I even take my healing abutment off, I want to go ahead and assess the adjacent teeth to see if there's any undercuts in that area. If there are, I use a block out material to go ahead and block that out. Why? We'll see that, right? Once that's done, I go ahead and remove the healing abutment, okay? And then you go ahead and place the provisional abutment, right? Or the temporary abutment or temporary cylinder, you can call it anything. Go ahead, place it in, and make sure it's all the way in, okay? Have the patient bite down. A lot of times, these temp abutments are about 10 millimeters long. So sometimes they can be really long, longer than what you need it to be. So you might need to cut it down, okay? So that doesn't interfere with occlusion. And the main thing is, once you seat it, you want to go ahead and confirm that it is seated down all the way. Of course, one way is to, feel for when it goes down. But when you want to really confirm complete seating, the thing I always use is a good periapical radiograph. Okay, it can be bite wing, periapical, doesn't matter. But the main thing is, you want to take a radiograph and you want to make sure that that connection between the abutment and the implant is completely closed. That has to be closed. If that is not closed, that means that the abutment has not seated all the way down. And so at that point, if you go ahead and make any occlusal adjustments, at the end, once everything is seated down, the whole thing is going to be much lower, okay? So the main thing is, you want to confirm complete seating of the abutment radiographically, okay? Again. So once that's done, you go ahead, cut down the temporary cylinder to length. And a lot of times when it's shorter than what I really want it to be, I also go ahead and sandblast it. I just take it to the lab, quickly sandblast it. Takes it less than 30 seconds to do it. Just a quick swish swish, and that's it. It has a perfectly rough surface for it to cling onto or basically attach to the provisional material. Okay, now you go ahead, place it back in, and you are ready to make the provisional. So once you have the wax up, right, you make your stent. On top of that, you can use a copy blast, you can use an Essex material of any kind, or you can also use putty, right? Different materials can be used for this. Doesn't matter. I like to use copy blast. So in my photos, basically you'll see copy blast. It's really thin. It's really workable, and with it being a little bit transparent, I can see what's going on the inside. If I have an air bubble, there's something I need to fill. So that's why I like to use copy blast for that. Once that's done, I make an occlusal access hole in the copy blast, and basically use a block out material of any kind, okay, to block out the access hole of the temporary abutment. Okay, in my case, what I've used is basically the back end of a cotton swab. For some reason, it fits perfectly into that into that provisional abutment, right, and blocks it out perfectly. I've never had any occurrences where the provisional material has kind of seeped in after I've put this in, just because of what a snug fit I get with this. But yeah, you can basically use anything. You can use PTFE, that's a Teflon tape, or you can use wax, or you can use PBS, anything that you want to. But the main thing is you want to go ahead and block out that temporary abutment access hole, right? Once that's done, you go ahead and fill it up with the provisional material of your choice. Could be either pro temp, or could be acrylic, anything that works well in your hands. Okay, once that's done, you go ahead, take it out, reduce the flash, trim all of that out, and what you want to basically create is a smooth transition between the platform of the implant and the final contour and the final shape of that tooth. Okay, now there's multiple things, multiple ideas, multiple theories in this realm of provisionalization. Some authors suggest making the temps to actual size and give the tissues a chance to heal and basically just push it out. On the other hand, you have authors saying that you want to basically reduce the size of this transition zone initially, give the tissues a chance to grow in thickness and mature. And once you're ready to finally restore it with the final crown, then you go ahead and make it thicker. And so basically the tissue is kind of pushed out, and that gives you a better aesthetic. Me, frankly, I use both of them, okay? Depending on the case, depending on how the gingiva is. I use both of those techniques, but 90% of the time, this is what I'm using, okay? I undersize my transition zone initially, give the tissues a chance to heal, give them a chance to mature, give them a chance to increase in thickness. And once that's done, when I change it from a provisional to a final crown, I make that area a little more thicker, give it a little more support, and basically now the tissue looks really nice and buzzed out, and so it looks similar to the other teeth as well. And there you go, you make a provisional. Doesn't matter what color it is. I got too excited and stained it a little bit more than what was needed. But as you can see, the main takeaway from this slide is that first, the occlusion of that provisional should be really light. You don't want it too heavy, right? Because if you think about it, the implant underneath is still healing, or even if it has healed at this point, the tissue is still maturing, right? So you don't want to apply too much pressure in that area for the implant anyway. So make sure that the occlusion is not too high, okay? Talking about anteriors, right? The same thing in the anteriors as well. The implant was placed in a number 7 position, or I'd say a number 1-2 position. Once that was done, you go ahead, once that's healed, you go ahead, place temporary abutment in there, and you cut it down to size. In this case, what we did was, once we made the provisional, just because of the color of the abutment, if you see, it has a mild goldish color, yellowish color to it. Sometimes it's okay because that's how the patient's other teeth are as well. But in this case, when we made the provisional, just because of the angulation of that implant, we were getting a lot of yellow hue in the incisal portion of that implant, which the patient noticed as well, and we didn't really like that as well. And so basically, we wanted to make something that was white on the inside. So could we have used a peak abutment? Yes, we could, but I didn't have that with me. So what we did was, you go ahead, cut it down to where you needed to, and cover it up with a little bit of composite. Once that's done, now it's white, right? Now you can go ahead and make a temporary on top of that. So if you see, it's not nothing real, it's nothing that's too complicated. It's not rocket science. It's just basic simple dentistry with basic simple materials that you and me, we have all used for such a long time. We use it every day, right? um but yeah, going ahead, that's what you do. The same thing, you block out the undercuts on the adjacent teeth. In this case, we whitened the abutment with a little bit of composite. Once that was done, the same procedure, you go ahead, place the stent on top, you block it out, push the material in, wait for it to set. Once that's done, you go ahead, add flowable, and develop that emergence profile. Okay, once that's done, initially this is how it looked, right, when we delivered it to the patient. However, we let the patient heal, we let the tissues heal for about 4 weeks after that. And so after 4 weeks, okay, we got a really good papilla fill. Does that always happen? Do you always get 100% papilla fill? Probably not. But what the most important factor is where the contact is for this case, right? For any case, for example, there was this paper by, I think, Henry Salama, or the Salama brothers. They were studying the position, or the position of the contact, and in relation to the papilla fill, or basically the papilla fill in relation to the contact points, the position of the contact between teeth. And so what they realized was that as long as you are about 5 millimeters from the bone, the level of the bone, you should get, you have a 95% chance of getting a good papilla fill. Okay, so that is one thing that is really important to me as well. So one thing is getting a good emergence profile. Second thing, placing my contacts in the right places. So I make sure that when I provisionalize, my contacts, the mesial and the distal, is about or less than 5 millimeters from the level of the bone. Okay, not from the tissues, but from the bone. Okay, that's one more thing to keep in mind. Once that's done, the papilla is filled as much as it could. Now is the time to go ahead and make an impression and keep going ahead. But yes, this is the difference that you'll see. Initially, when you just remove the healing abutment, the tissue is just round. It doesn't have any specific shape to it. But after you're done with the provisional, this is what you should see. Okay, if you see this after the provisional is taken out, bravo, the provisional has done its job. Okay. Once that's done, you go ahead, place it in. Okay, this is how it looks in the patient's mouth. Patient was really happy. Okay, after this comes the impression procedure. Okay, but before we go into that, this was initially we discussed how you can make that directly in the mouth. Okay, if you don't want to do that, there's another way you can do that, is make a provisional, is you can do it in the lab. So basically you go ahead, take the healing abutment off, and you make an impression, transfer it to the impression, and once the cast is poured, then you go ahead and do this exact same procedure on a cast, right? So using a closed tray healing abutment, we went ahead, made an impression, poured a cast, made the gingival moulage. And once that was done, you go ahead, put a temporary abutment on it. And the same way, you go ahead, you sculpt that area of the crown, make it really thin on the inside or on near the implant, and smoothly transition it to how the contours of the teeth needs to really be. Right? That's really key. So you want to have a real smooth transition between the shape of the implant and the final shape of the crown too. Once that's done, you go ahead and place it into the patient's mouth, wait for it to heal, and that's and wait for the tissues to grow. Okay. Going ahead, talking about full arch provisionalization, Dr. Shovik did an excellent job of explaining full arch and hybrids. And so this is going to be a really short slide about that. You can use the existing denture to provisionalize for a full arch case. You go ahead, place the healing abutments in, make room for the healing abutments in your denture, pick them up with pink acrylic. And on the top right is what you initially get when you pick those up. Make sure to see where it touches the tissue, mark that, and then reduce the pink portion all around that area so that you can get a good convex underside of that or the intaglio of that prosthesis. Okay, that is really important. You don't want a concave shape, because what happens is, since this is a fixed prosthesis, the patient cannot really remove it. And so any food, anything that goes underneath it becomes really difficult for the patient to access with any cleansing aids, whether it be the dental brush or floss or the spongy floss or anything. It becomes really difficult to basically clean that area. And so basically you want to keep that area really convex and smooth so that the patient can actually clean that area well. Okay, and again, there's a lot of things that go into this planning, and Dr. Shovik did an excellent job for that. So I'm not going to go into that again. Going ahead, talking about, once you've developed that tissue, once you're happy with it, the patient is really happy with it as well. You want to transfer that to your final impression so that you can go ahead and, duplicate that into your final prosthesis, whether it be a single crown or a bridge or full arch of single crowns or bridges, anything. The main thing is you want to transfer that specific contour that you have developed to the final crown. So the way you do that is by using, of course, you use impression copings. Again, you can do impression either at the implant level, or you can make an impression at the abutment level. There are different cases where you might want to go one way or the other. For single crowns cases, I generally go for the implant level impressions if I'm making a bridge, 3-unit bridge or even longer, where the implant angulations are a little bit off, and you don't have a specific parallelism to go directly to the implant. That is where I would go ahead and make an abutment level impression. Just a second. I think there's something beeping on my Zoom here.
Go ahead, Dr. Arpit, go ahead.
It's okay? All right. Okay. So going ahead, you can either pick it up directly into the impression, or you can go ahead and transfer it later on. So basically, same thing as a closed tray versus an open tray, right? So for example, the first abutment that you see on the left is a transfer impression, right? So what you could do is you go ahead, screw it into the implant, make sure it's seated all the way in, make your impressions, take it out, and then go manually. You have to remove the abutment from the implant, from the mouth, and then place it into the impression. On the other hand, the other type of the impression coping is a pickup impression coping, which has notches built in to kind of engage that impression material. And so what you need to do is, it's basically an open tray technique where you make a hole into the area of where that implant is, And generally, these abutments are longer than the pickup abutments or the closed tray abutments. And so what you do is, once the impression tray is filled up with the material, you go ahead and place it in. This being longer, of course, it will stick out to that hole, and you remove the excess material. You expose this, and once the material is set, you go ahead, loosen it, and then the whole thing comes off together. Okay, so that's the basic concept of this. The main thing is, either way you go, you have to confirm seating of the impression coping. Okay, and just like we did with the temporary abutment, you have to go ahead and make a radiograph of this before you even go ahead and make the impression. Okay, this is like of paramount importance. Okay, because if the impression coping isn't seating in all the way, your whole impression is of no use. Because if you make a provisional or a crown on that position, it's going to turn up in the wrong position and you won't be able to use it. So basically, you want to confirm the complete seating of that coping with a radiograph. Okay, whether it be an anterior tooth or posterior tooth, any tooth, you want to confirm seating. For example, if you see in this case, both of them, two different implants. One is a premolar side, one is a molar side, two different sizes. But you can see that the connection between the implant and the impression coping is completely closed, right? You want to confirm that, you want to see that it is completely closed before you make the impression. Okay. Once that's done, you go ahead and make your impression, and you go ahead, take your impression out. This is how, can you see my mouse or no?
Yes, I can see. We can see your mouse.
Oh, excellent, excellent. So you can see the pointer. That's nice. So once you go ahead and take the impression off, this is how it comes off, using the closed tray technique. On closer inspection, you'll see that, especially systems like Astra, the way it is designed is the whole abutment is generally round in shape, right? Except there's one portion that is flat, one side that is flat. Why? Because that acts as your index. Okay, that way, once the impression is done, the material is set. Now you want to go ahead and insert the whole abutment analog complex into that area, and there's only one way that it'll go in, and that way is where the flat face aligns with the flat face of this impression. Okay, so basically that acts as an indexing feature. Okay, once that's done, you go ahead, place it in. You want to make sure that you feel a positive click when it goes in. You want it to seat all the way in. It basically pops into its final position. Okay, you want to feel that. You don't want a mushy feeling at the end. You want a definite seating feeling at the end. Okay, and you'll get that. Talking about pickup impressions where you have more implants. For example, if you see this, what I like to do is generally when I make my full arch or multiple implant impressions, I want to generally splint my implants before I do that. Okay, so what we generally do is you go ahead, attach the impression copings to the implants, right, and then you tie a floss around it, basically act as a substructure for the jig, right? And once that's done, I generally like to go ahead and on the cast, before it's done, before I see the patient, I want to make this jig. So what you do is you go ahead, add pattern resin or duralay, and once that's done, you section it. Okay, so why do you want to generally section it? Is because in case if one of them doesn't go in all the way, then your impression is wrong. So you don't want that. So what I do is, once all of them are sectioned, I place them in the patient's mouth separately, right? Just like on this area. Once that's done, you want to, again, make sure that all of them are seated. You know that all of them are seated. You know that all of them are passive. Once that is done, you go ahead and add a little bit of duralay, close that gap, and now you are completely sure that it is passive, it is closed, and now since everything is connected, everything is positively splintered together. Okay. Then I go ahead and make my impressions, pour it in the cast, and then this is my master cast that I sometimes verify as well. Okay. Once that's done, you go ahead, add your impression and the implant analogs to the copings, pour it in the cast, and that is where you go. You go ahead and make your moulage and all of that. Okay. So once once the impression is done, okay, the second thing you want to do is make a custom impression coping. For example, actually before the impression, a lot of times when I'm working with aesthetic cases, say an anterior case where I'm really happy with the way that I've designed my emergence profile, okay, you want to go ahead and copy that. You want to duplicate that into your final prosthesis. And so before you make the impression and after you remove the provisional, you don't want the tissues to really change. So what you do is you tailor the impression coping to that specific site to support that tissue and then transfer that shape to the impression, right? And the way you do that is you go ahead, remove the provisional, right? And you make kind of an index of the emergence profile of that provisional. Okay, usually use a medicine cup that we all have, generally in the dental office. Fill that with stone. I put my implant analog in that with PVS or exabyte. Basically, you go ahead and make an index of that area in the impression, in the emergence profile, basically, of the provisional. And you go ahead, attach your impression coping in that area, and I fill it up with either, you can fill it up basically with anything, like resin, or it could be pro-temp, acrylic, anything that works well in your hands. Generally, I like to use Durolay because generally it has very less, um, polymerization shrinkage. And so I know that the shape is going to be stable even after it sets. Once that's done, I go ahead and place it into the patient's mouth, right? I place it into the side. I make sure that it is placed well and it is seated all the way down. You go ahead, of course, take the radiograph. In this case, we are making a close to impression. So we went ahead with making the impression, and you transfer that, the same thing, to the cast as well. And then you notice that the exact shape that you had of the tissue in the mouth is transferred predictably to the cast. And now you can go ahead and make your final prosthesis on this. And so when you actually seat the final prosthesis in the patient's mouth, there is very little discomfort for the patient. Okay. Another way is, with a 3-unit bridge. You can do that with, simple impression copings as well. So what I do is I take my provisional, the same technique you can do with a bridge as well. And this is what I've done in this case. So take a medicine cup, take the provisional, mount it in stone, in basic mounting stone, right? Let it set. Once that's done, you go ahead, use PVS around it, take the provisionals off of the implant analogs, and fill it up with Pro, right? Once that's done, I go ahead and place it into the patient's mouth and make the impression. Again, it doesn't need to be pro-temp. It can be pattern resin or Durolay. Anything that works well in your hands and knows that it's going, and that it's going to be stable. For example, in this case, we used Durolay. In the earlier case, I used Pro-Temp. So it was good. It worked out well for me. But generally, I like to stick to Durolay for such purposes. And so finally, this is what you get, and this is how you transfer the shape of your provisional and your emergence profile to the final impression, and then you deliver the crown, and generally, the patient is generally happy because now the implant aesthetic is specifically tailored to that specific case and to that specific site. And Generally, this is what has worked out well for me. Um, the second thing is, how do you assess implant aesthetics? And there's multiple ways of assessing implant aesthetics as well. If there's a particular outcome, how do you know the outcome is good enough? Um, so there was this paper by UC Pelser and the whole team, in 2009, where they reported a good rubric to use. So they said there's something called a pink aesthetic score, and then there's the white aesthetic score, right? So there's certain things you see. You want to see the height of the mesial papilla. Do you have good fill or no? Compare that to the contralateral tooth. Do you have it exactly the same? Yes, you give it a score of 2. It's like, okay, it's more than nothing, but it's there, but it's not completely there. You give it a 1. And if there's nothing in that area, you give it a 0, right? So basically, um, factors like the distal papilla, the mesial papilla, how curved is the facial mucosa, right, on the facial of the final prosthesis, or what is the level, the the coronoapical level of the mucosa. Does it match the contralateral tooth or not? Based on that, again, you can give it a score of 0, 1, or 2. And finally, the color, the texture of that gingiva, or basically the peri-implant mucosa, does it match the rest of the tissues? Yes or no, or maybe you give it a score of 0, 1, or 2. So basically, with all of these 5 factors, you have a maximum score of 10. However, going ahead, there's also the white aesthetic score, wherein you're looking at the tooth form. Is the tooth shaped right or not? Is the texture right or not? Is the volume good or not? Is it supporting the tissue well or not? Is the color good? Is the translucency good or not? Is the characterization good or not? So basically, these are the factors you assess and then give it a score of 0, 1, or 2. And so in a perfect world where everything is perfect, a maximum score would be 10, or would be 20, actually 10 for each. And basically, there was a study by Dr. Will Martin from UF, and his team, and he said that he compared the patient's expectations, and they found out that a score of 12 is what is generally needed, where the patients don't see the difference from 13 to 20, right? So you generally, to get a good aesthetic outcome, the minimal best West score that's needed is a score of 12. So that was a great finding as well. Going ahead, once that's done, this is after you place the provisional, or place the prosthesis, right? The final prosthesis. Um, Sometimes you have to see things. You want to predict whether a particular case would have a good aesthetic outcome or not, and that is where the ITI suggests using the aesthetic risk assessment table, which I feel was a perfect table, a perfect resource to use for any dentist, right? For any kind of case. This is what I use with most of my cases, for I'd say almost all of my cases. Um, and there are certain factors where you want to look at to predict whether, after the placement of the implant and the restoration of the implant, is my final aesthetic going to be good or not? Or is it going to be easy or not, right? So there are certain factors that you want to look at, and some of them there's a spectrum, but some of them there's a definite yes or no. For example, with a crown prep, right, you can have a taper, a good, medium, or a bad taper. But having an undercut, you cannot have a okay undercut, right? There's either you have it or not. So they're different. Similarly, there are different parameters in this table as well, that either have a spectrum or it's a definite yes or no. Okay, that make the decision. So if you go ahead and look at the table, things like the medical status. Does a patient have an underlying systemic condition that affects healing? Yes, then that's a high risk factor. If no, the patient is really healthy, there's no problem healing, that's a good thing. Does the patient smoke? Yes or no? How is the gingival display? How is the smile line of the patient? Is it low? Everything's good. Is it medium? can or cannot be good depending on how the outcome is. But if the patient has a high smile line, now there is a lot of aesthetic risk, right? If everything doesn't turn out well, then it's going to look bad, right? So there's a lot of high risk. Do you have the edentulous span? Do you have enough restorative space, right? So for if there's the one tooth, you generally want about 7 to 8 millimeters of restorative space, or at least a minimum of 6, right? If you have that, well and good. If not, and you need to restore more teeth, right? Now everything's going to get tight. And once the space is tight, you have problems with prosthesis breaking, you have problems with, as we discussed, emergence profile. And that's where things get, difficult. And so that's where the aesthetic risk is high as well. Shape of the crowns of the natural teeth, if it's a general square shape, everything is good. It's a more rectangular shape, everything is good. But when it's more of a triangular shape, right, the height of the papilla is really high. So that gives you a very high risk as well. Okay. Same thing, going through the neighboring teeth, is it restored or not? Implant site, is it good or not? Do you have enough bone? What kind of gingival phenotype is it? Is it a thin gingival biotype, or is it a thick gingival biotype? If it's a nice thick gingival biotype, you are sure of, well, at least not, you can never be sure, but at least you're more hopeful of getting a good soft tissue fill. But if it's a thin tissue biotype, right, you put the probe through, you can look at it, or when you're placing an implant, you see less than 3 millimeters of that tissue, you can kind of, predict that, okay, possibly I might not get good papilla fill in this area. Talking about the bone level, where is the bone level? How much bone do you have? What quality of bone do you have? Right? Is it natural bone, or is it bone graft? And even if it's bone graft, is it corticocancellous, or is it, xenograft? The, makes a lot of difference. Um, Finally, you want to also look at, the anatomy of the alveolar crest. If there's any bone deficiency in that area, is there vertical bone deficiency, horizontal bone deficiency? These are the factors you want to look at before you even start planning with your case. However, all these factors aside, one of the most important factors you want to take into consideration is the patient's aesthetic expectation. What is the patient looking for in this whole treatment? Does the patient want something to just cover that space up? Or does the patient want something to look perfect? Is the patient, what does the patient want out of it, right? That is the biggest thing. And what happens is, usually doing this table, filling out this table in front of the patient, helps both of us, me and the patient, because the patient can see that different things have an effect on the final aesthetic outcome. For example, smoking. If the patient is a heavy smoker, the patient knows that he's a heavy smoker, right? And that's a higher risk to the development of a good aesthetic outcome. And so it builds up, it helps tailor my patient's expectations of the final aesthetics as well. And so that is why I feel that this is one of the most important things, right? To basically program, to educate the patient and program their expectations to what you can deliver to them realistically. Okay. And so in general, I want to keep this lecture really short. I don't want to go too long on this, but the main takeaways from this, my little presentation, is that first, the aesthetic, the final aesthetic of the implant is, um, you know, basically complex of carefully developing that tissue around the implant and being able to transfer that contour, transfer that shape of the tissue predictably to the lab so that you can go ahead and make a final prosthesis that closely matches to your to what you have developed, right? And we worked so hard to develop to. The second thing is I always use the ERA table, or the aesthetic risk analysis table, to assess my aesthetic outcome even before I've placed my implant, right? And I also use a Best West score to assess how I'm doing in general with my aesthetic demands from the patients, right, or from the prosthesis? Have I done enough? Is there anything else? For example, if I feel that, okay, I don't have enough soft tissue, probably we might need to go for a soft tissue graft or a bone graft. We need a little bit more support. So basically, it tells us a lot, right? There's just certain factors that you want to look at, and so you want to use the best West score table as well to assess your implant aesthetic. And just making these small changes would make a big change to your practice and your outcomes in implant dentistry. Okay, and that is pretty much it.
Thank you so much for wonderful. This is like for those who are residents or practicing, this is as practical as it gets, in terms of making. We need to bring you back, Dr. Arpit. We're going to split it into two, because you have talked a lot of, you've given a very, very concise lecture, but I need to, as you were speaking, I'm like, I need to bring you back just to talk about provisional restorations for a single, then a multiple. That's one lecture by itself. Then another one, impression taking, which is totally different. So thank you so much for being able to bring all this together. I want to go ahead and run the poll. I know we have some questions on there. So guys, we do have some poll questions. Please go ahead and answer them. And Dr. Arpit is going to give us answers to these questions at the end. You'll have let me give you like 6 minutes to answer these questions.
Hi, guys.
All right. We're still answering the questions. Almost halfway there. Let's go ahead. We have 51%. Yeah. Everyone, we have 2 more minutes. We have 1 more minute for you to answer, send some answers here. We have 60% participation, which is good. We can get some more. All right, I'm going to end the poll. I'm going to share the results here. Dr. Arpit, could you please go ahead and give us the right responses?
Sure. So coming to the first question, right? What is the best way to confirm the complete seating of the impression coping or the temporary cylinder? That's right. The best way is to use a periapical radiograph. Yes, you can also have a tactile feedback. However, the best way, the most sure shot way of making sure that it's seated all the way is the periapical radiograph. You don't want to see that little gap, just like we discussed. Going to the second question, what is the maximum distance between the bone crest and the interproximal contact where there is the most predictable papilla fill? Again, just as we talked about the study with Salama and the team, it should be 5 millimeters from the bone, right? It's not from the tissue, it's from the bone. The mesial and the distal contact, or the proximal contact basically, should be about 5 millimeters or less from the level of the bone, right? So at about 5 millimeters, you get the most predictable papilla fill. Any more, and the predictability of papilla fill goes down, okay? What is the most predictable way to transfer the emergence profile of the provisional implant crown? That's right, most of the people got it right. It is the custom impression coping. Yes, you could also place the impression material directly in near the around the impression coping. However, the time it takes between when you remove the provisional and you place your impression coping in, and within that time, the tissue can actually collapse a little bit. And so you might not get the most accurate representation of the emergence profile if you just directly place PVS into that area. And basically, so to get the most accurate representation, the best way is to use a custom impression coping, okay? What contour is generally preferred for the intaglio surface of a fixed implant complete denture or hybrid? So there we go. We have a very close 50-50 between convex and concave. The right answer is convex. You do not want it to be a saddle shape. You don't want it to be concave. Why? Because if it's concave, it is a food trap, okay? And it's difficult for the patient to clean. And if it's difficult for the patient to clean, it'll be it's detrimental for the long-term prognosis of the implant as well. So basically, you want it to be nice and convex so the patient is able to clean, right? What is the ideal amount of time for blanching to disappear after placement of the new provisional? So what happens is every time you support the tissue, you place the provisional in, you are applying pressure to that tissue, right? So when that happens, when you apply pressure to tissue, right? You apply pressure here. What happens? You see blanching on the soft tissue, right? So the same thing happens in the peri-implant mucosa as well. When you place the provisional in, how do you know that you have not built up too much, or are you within a good range? What you do is you look at the blanching, right? If the blanching goes down, right, between 6 to 10 minutes, you're okay. Any more than 10 minutes, and the tissue is going to go down, right? It's going to recede. Why? Because the pressure is too much. Okay, if there is no blanching at all, you know that, okay, there is no pressure being applied to the tissue, so the tissue has some room to grow as well. However, within 6 to 10 minutes is generally where I want to be, and that is what I do for my patients as well. That has generally worked out well in my hands. So even in studies, they say, generally 6 to 10 minutes is a good amount of time to wait for the blanching to go away, and that is what is considered normal. Going ahead, what is the appropriate depth of the implant placement in relation to the planned mucosal margin in order to obtain an ideal emergence profile, right? So the right answer is 3 millimeters, right? Now, think of it. This is not from the cervical of the crown. This is from the planned mucosal margin. Where do you want the final margin of the gingiva to be? You take that point, reduce 3 millimeters. That is where the platform of the implant should be. So that is where you need to place that implant. So that's why the right answer is 3 millimeters. So there you go. There we have all the 5 questions. And let me know if there's anything else I can help with. Anything, any question, any doubt, anything I can help with?
Okay. I think there's a question out there, but I wanted to ask, when do you so you place the implants, and when do you place the provisional?
So what I do is, so loading depends, right? Depends on how the implant is placed. Generally, I wait about 4 to 6 weeks before I provisionalize the implant. So 4 to 6 weeks, my implant is either covered with a healing abutment, or it is covered with a cover screw. So I generally wait about 4 to 6 weeks after implant placement.
Okay, so for a case where there's an uncovery that has to take place.
Yeah.
The what? So if it was the implant was buried, and closed up, and you needed to make an uncovery, your temp.
Yeah. So depends. So if the placement has been about 4 to 6 weeks before, my general concern is that I want the implant, the bone around the implant, to heal before I go ahead and start putting occlusal pressure onto the implant. So at that point, I'm not as concerned as much about the tissue as I'm about the implant. Once I know the implant is solid, the healing is beautiful, then I can then controlling the soft tissue is what I'm doing with the provisional. So in a case where I am uncovering an implant, I make the provisional on the day of the uncovery. You can do that as well.
All right. So there's a question here. It said, I've not been able to understand why the intaglio surface of an implant needs to be convex.
So that was referring to the intaglio of the fixed implant complete denture, or hybrid. Yeah. Right? So basically what happens is you have the alveolus, right? Now, if it's concave, right, and the intaglio is seating down all the way, now it's difficult for the patient to put anything in to clean the food and other things that have gotten in, right? However, if it is convex in shape, right, it is still touching the mucosa, but now you have good access to keep it clean. And that is why it needs to be convex.
Okay. Anyway, Dr. Otua, is that clear? Anyway, if you need some more clarifications, I'm sure we can communicate via email. Thank you so much, guys. I do have Dr. Kwayemi Okioso. Do you have a question? Your hand is up. Aquarium, you are able to speak if you want to.
Okay. Yeah, no, I pressed it by mistake, but I just want to say thank you to Dr. Arpit for the wonderful presentation. Thank you so much.
Thank you so much. The pleasure's been mine.
All right.
Great work, doctor.
Thank you. Thank you. I mean, this has been an amazing lecture. Believe me, we're going to try to get Dr. Arpit to come back. I know he's a busy man, but we're going to try to bring it back and make it a little. We're going to split it into two: one on impressions and just the different types of impressions and all that, and one on provisional restorations for the single implant and for the multiple. There's so much on there for those who are already doing this, this is like, you know, it's a Mecca presentation. Very, very good place to return to. So these videos are going to be available on YouTube, and you can actually listen to them, go back and refresh, check your books, and very good. Thank you so much, Dr. Arpit, for joining. Dr. Shubik, are you on there?
I'm here, Uvo.
Yes, I do. So somebody had a question for you. I skipped that. He said, following extraction of the standing teeth in one of your cases, how soon can you place the zygomatic implants?
That's a good question. So in that case that I showed, we actually, we placed the zygomatic implants at the same time that we extracted the teeth. So the idea behind that is twofold. One is it has to do with the biomechanics of the zygomatic implants, and the other is the concept behind cross-arch stabilization. So in the literature, in the biomechanics literature for zygomatic implants, what they did is they found, they did what's called finite element analysis. So they go in and they use computer modeling to see where on the skull certain forces are being concentrated in a zygomatic implant. So basically what they found is that majority of the stability and the forces in a zygomatic implant was actually in the zygomatic bone. And that's because of the cortical dense nature of that bone. They does get some stability from the alveolus in the maxilla, but majority is from the zygomatic bone.
I see.
So for that reason, regardless of the condition of the bone in the alveolus, meaning if you take out a lot of teeth and you don't have great quality bone, we still place the zygomatic implants in the same surgery. So that's an immediate placement. And then we actually load that prosthesis. And the idea behind that is called cross-arch stabilization. So when we have, it's actually contraindicated to bury zygomatic implants. And that's because they are strong occlusally, but they need lateral stabilization from the contralateral side, and that's called cross-arch stabilization. So to answer the question, you don't have to wait. We do it right away, immediate placement and immediate loading.
Okay. Do you have to do any grafting? Have you had to do any grafting when you do that?
Yeah. So when there's a whole whole lecture for zygomatic implant, but basically to sum it up is you can place a zygomatic implant kind of along the lateral maxillary sinus wall, and if you're within the sinus, I like to do some grafting to cover the implant. But a lot of times, the times I do it, I actually place it laterally. That means a little bit outside of the maxilla. It's called a lateralized zygomatic implant or extramaxillary zygomatic implant. So grafting around the implant with bone is very unpredictable, but we graft it with tissue. So typically buccal fat pad. We also take pedicle subepithelial connective tissue from the palate, and we pull it around. It's called they call it a scarf graft. Aparicio published on that. So it's more a soft tissue grafting than the hard tissue is unpredictable. So most of the time I don't put any bone grafting over it.
Okay, okay. I mean, I guess, Dr. Shubik, you are here forever then, because after you come back again, you're going to give us another one on zygomatic implants.
I'm happy to.
Anyway, I'm going to call on Uwem Akwang. You're a dental student from Nigeria. You have something to say?
Okay, my question on the grafting has been answered. You asked him and he addressed it.
Okay. Anyway, thank you, Uwem. At what stage are you in your dental training?
500 level.
Okay, so you have one more year to go.
Yes, sir.
All right. Anyway, I want you to use your social networks and get all the Nigerian dental students on this blog. Tomorrow we are back here with Dr. Casabre and Dr. George. We're going to be speaking on. I want to see some Nigerian students. I want to see some Nigerian students here. There are a lot of Ethiopian students. The Ethiopians have taken over. They are all here, and very few Nigerians. A lot of Nigerian practitioners, but very few Nigerian students. So please, let's use our networks. They are here to gain. Anyway, thank you. No problem. I'll look forward to seeing you tomorrow. Thank you, Dr. Shubik and Dr. Arpit. You guys have you given a excellent presentations this Saturday.
Thank you. It's my pleasure.
All right.
Thank you, Ugo. Anytime.
All right. Thank you so much. Okay, see you guys tomorrow. We'll be back on, and looking forward to seeing you.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator